All right, C, choice of sedation. So we're moving on to letter C. So that's, we will talk about sedation in more detail with IV titrations and like what their indications are, who should get it, what the complications are. So we're going to kind of just do like a C for cursory review of our sedation, okay? But what we do know is that we don't go up on sedation first, right? We go up on pain meds first. All right, so our goal for sedation is light, right? Sometimes you say, oh no, we're going to put you to sleep and wake you up in a couple days. That has more mortality, more ICU length of stay, more hospital length of stay, and it causes more damage to the patient. Damage as in death, right? So we want to make sure that we are just doing light sedation. So how do you know someone's lightly sedated? The RASS, right? So the RASS of 0 to -1 is what we want for someone that is adequately sedated, right? They're not too agitated, right? They have ventilator synchrony. There are other reasons why you have sedation, right? There is ventilator synchrony, like they're desatting. Well, shoot, let's increase the sedation, right? But the other things are like neuromuscular blockade. Obviously, we want sedation on board. They are seizing. That's someone that needs to have sedation on board. Okay, so you titrate for ventilator synchrony, and then also we titrate to a RASS of 0 to -1 so that we can get them down to an optimal place for where we can just, going from 5 propofol to 0, easy. It's a little bit much easier than 50 to 0, right? You get a little more anxiety when you're going, oh, we're going off, let's see what happens, right? So it's better to try to wean throughout your shift. Okay, so we want to make sure we fix the pain first, and then we'll titrate up our sedation. We do the wake up and breathe or the SAT trials every 12 hours. Mobility is going to help our patients to fix their delirium, which might be causing their agitation. You look at this little box right here, you can see all the things that lead to the 3 different things that cause agitation and a patient to be agitated in the ICU, right? For a RASS score that's greater than 0. So we got pain in the middle there, right? We got delirium, we got agitation, right? So delirium causes agitation, pain causes agitation, agitation causes pain, pain causes delirium. So you got that happening in the middle there, but then you follow, someone comes in, it's like, hey, let's give Ativan. Well, Ativan causes delirium, which causes, it's going to go over and over and over, right? And then you have someone that doesn't give medication before they do a bed bath or before they do a wound change, and that causes pain. And then they, on the ventilator, more and more sedation, right? So we have, they have other comorbidities that might put them at risk for delirium, such as they have Alzheimer's. They're a lot more risk for delirium compared to a person who doesn't have Alzheimer's, right? You have someone, you're putting vascular access in. We have someone that is hypernatremic. They found that if a sodium over 143 is a sign of poor ICU care. There's no reason someone's sodium should be more than 143 when you're in the highest level of care in the hospital. There's absolutely no reason for that. So we have ways to fix that. We have free water flushes, we have D5 water, we have all kinds of things we can do. And when you're thirsty, I think someone's drinking water right now. So when you're thirsty, you get a little agitated. It's like, I'm really thirsty. Like after a long hike, right? Like our charge nurse walked 18 miles yesterday. So I bet if she didn't have water, she'd be super, super pissed off, right? And really delirious and agitated. Like, get me in the car. I need to get to the 7-Eleven. I need an icy right now. Right? It's not the best thing to cure dehydration, but those things cause problems, right? Same thing with hyponatremia. That can cause agitation as well. Okay, hypoxia, we know hypoxia can do it, and all these things should make sense that lead to all this interaction between pain, agitation, and delirium. So our goal is to fix pain by assessing it and treating it, and fixing and providing sedation if we need to help calm this down, right? And sedation, as we'll learn, there's, you want to get as little as possible because more sedation leads to more delirium, right? So these PAD guidelines, so pain, agitation, and delirium, that's what we're trying to be focused on. We're trying to fix the pain, we're trying to fix the agitation, and fix the delirium, right? We have different medications that can fix each one. And we should objectively measure it. We shouldn't just say, yeah, they're a little agitated, right? So you want to have an actual number attached to that. Are they RASS +1 or RASS +2? Because RASS +2, I'm probably getting some antipsychotics ordered or some other things to improve the sleep-wake cycle, or get their dentures from home, or not dentures are vented, but get their hearing aids from home, get their glasses, something to fix their problems, right? So you can assess pain with the numerical pain scale, the CPOT, etc. Agitation we can assess with RASS score. The BIS sensor, that's something we use with paralytics. It's a way to assess if someone is adequately sedated. It's a way to assess if you're 0 to -1. We'll talk about it in IV titrations. But what is a BIS? BIS is a BIS right here. So it looks like that. So then I laughed myself out of my office this morning when I reread this. I felt really geeky. Anyways, we have EEGs that we can do, continuous EEGs, to measure if someone is adequately sedated. And again, it does not cause REM sleep. So you're not going to see like alpha waves and such when someone's on propofol. You're going to see just they're knocked out, right? And then delirium, we assess that with CAM-ICU. All right. So all these things lead down the path to the dark side. Okay, so what is minimal sedation? So we said it's a RASS of what? 0 to -1, right? So this is in policy. So it's there. So someone says, oh, what's your policy? It's 0 to -1. I wrote the policy, and also I made sure that the policy matches the new SAT SBT criteria. So it's 0 to -1 is what you want. Because we said it's -1, -2, you're gonna have more sedation overall across how many of our patients we serve per year, right? Which is about 2,000 to 4,000. All right, so we have a lot of opportunities to improve we have opportunities to reduce the amount of sedation we give, right? So we 0 to -1, and that's based on literature. It's not just something I made up, right? So it's something we want to make sure everybody's at 0 to -1. So what is 0 to -1? That is someone that has alert and calm. So again, that's when you're walking in the room, they give a little what's up with the eyebrows, right? Or they give a little rock eyebrow, right? So that's someone that is alert and calm. Or you walk in the room and you're just like, what's up, right? You're like, Julius, what's going on, right? And they're like, they open their eyes, like they get a little rock, they get a little eyebrow as well, right? Or they just put their arms up for a fist bump, or they get a little thumbs up, right? So that's someone who is 0 to -1. And also they have to look at you in the eyes too. That's something that's, you say, is a -1 versus a -3. We'll role play this when we talk about neuro, so you can get really comfortable with RASS scores and also CAM-ICU scoring, because you need a RASS score for the CAM-ICU. But why would someone not be 0 to -1? Why would you want -3 or -4 or even -5 where nothing wakes them up? Why would you want that? Surgery maybe, yeah. So yeah, you want ventilator synchrony, right? They're really desatting. They're at sats like 86%, and they have ARDS. They have the pips and plats are crazy, or they have someone that is, they're not oxygenating. That's someone that we need to put the sedation up on. Okay. And if they're paralyzed, like for surgery too, you definitely want to have paralytics. You want sedation on board when you have paralytics, right? And then you someone have actively seizing or elevated ICPs. We need to have deeper sedation in those situations. But if you don't meet this criteria, there is no reason to be on sedation, right? So even in kind of the ballpark, we even have it in the mobility protocol, 60% FiO2 and PEEP of 8 and less. Really, there's no reason for that. We have other medications we can give besides IV sedation. Okay. So why is it important? We want to make sure that we can, wean them, because again, it's easier to go from propofol of 5 to 0 versus 50 to 0, right? Keep them awake or alert and calm throughout the night, because people can sleep. And now when you have sleep, that avoids delirium, right? Because if you don't get sleep for 3 days, you're going to get really agitated, right? What else? So yeah, mobility we can do. This is from the mobility protocol as well. And then delirium assessment. And we'll talk about CAM-ICU more when we talk about neuro and assessing someone with agitation. All right, so sedation is titrated first or last?
Sedation is
titrated last because we should be giving pain medications first to see if we can get them to improve their agitation. So if their RASS is +2, +3, let's give some pain medications and see if that's the reason why they're agitated, right? So kind of just a brief, like how does the RASS score work? Agitation kind of makes sense. You walk in the room, they don't give you a what's up. They flip you off and they start pulling their ET tube, right? They just start squirming in bed, or you walk in there like, this is the day I'm going to have. This is it, right? It's like when our nurse this morning walked into her room and he started spitting on her. It's like, okay, that's a RASS of +3, +4, right? So I'm going to get some medications to kind of fix this, right? We're going to try to fix the situation. So that's a RASS of +1, +2, +3, +4. +1 just squirmy, +2 is really squirmy and they're actually trying to reach towards their IVs. That's a patient usually restrained. +3, they're really pulling. +4, they're a danger to themselves or others, right? And then 0 to -1 makes sense. You're just walking in, you're just taking a look at them, and they are awake and alert looking at you. When we say -1 to -3, that's someone that opens their eyes. Now, do they open their eyes purposefully, or do they open their eyes to command? And what the command is look into my eyes, right? You say, Ashley, look at me, right? So I'm going to say, look at here, look. More than 10 seconds is a -1. Less than 10 seconds, like, no, you look ugly, right? That's a RASS of -2, right? So yeah, -1, -2. You might like turn the Barry White on the TV. It's like, okay, let's look at me right now, right? So that's a -1 or -2. If they can't look you in the eyes, but they wake up, that's a what? That's a -3. They open their eyes, but they do not make eye contact, right? So that's how you score a RAS patient. That is, they respond to voice of some sort. They're -1, -2, or -3. If it requires you to touch the patient, you're automatically a -4 or -5, right? So if you touch the patient, I mean, sometimes you can gauge, like, you know, they were like really deep sleep. But if they, you know, it requires you to like really touch the patient or even do noxious stimuli to really do, you know, your pinchy nails and such, that is a -4 if they wake up. If they don't wake up, it's a -5. Okay, so that's our goal. So we're making sure that we are assessing the RAS so we can get everybody's sedation down to a low enough level so it's easier to get them off the ventilator, right? So pain, is the pain a problem? If it's not, agitation, we can titrate sedation. And is it a delirium problem? Is there something we could fix non-pharmacologically or even pharmacologically to adjust to get their agitation and delirium under control? Okay, so who gets a RAS score? Everybody. Everybody gets a RAS score done. Okay, so what RAS score is this?
Chrissy, wake up! I don't like this! Chrissy, wake up! Hey, hello? Time to wake up, time to wake up. Can you hear me? Wake up, Chrissy! I don't like this! Chrissy, wake up!
What is that?
So -5. I don't know.
Well, she opened her eyes. So that's technically a -3. I might give her a -4 too, but yeah, -3. I'm going to look for some confounding factors like demonic possession. All right, so what else? So sedative agents. Again, we're going to go in more detail with this with IV titration lecture where we talk about the different medications we can give. But just so you know, we kind of really be talking about Precedex, right? Dexmedetomidine. That's a great IV sedative that we can that is also provides analgesia. So it's a analgesic sedative. So it provides analgesia and also sedation. Propofol is great, but it provides no pain control. So we got to be aware of that. It's like, why are they super agitated? They're on propofol. That doesn't fix their pain. So we can see, do we need to give PRNs? And if the PRNs aren't working, let's try some IV infusions of sedatives, right? Oh, sorry, of narcotics, or opiates, I should say. All right, so opiates are like morphine, Dilaudid, and fentanyl as an infusion. They provide pain control. They also provide sedation, right? So you can have fentanyl for a RAS score, technically, but really its primary goal is to fix the pain. And then we have ketamine, which is our, getting more favor nowadays, and ketamine does do pain control and sedation. Okay, so what is red here that you should not be using are benzos. So benzos are independently increase our length of stay and our mortality and delirium. So it's not great to give benzos, right? If we have a choice, yes, sedation does all those things too, increases mortality, increases length of stay and hospital length of stay, but it's not as bad as benzos because benzos also increase delirium in and of themselves. Okay, and then again, IV sedation is not needed for forever until you're ready to come off that day. You can get them down off sedation once they're like at 60% FiO2 or less, and we can starting PO sedatives or even like kind of overlap it, right? So PO analgesia, so Tylenol does wonders, right? People might scoff at you, it's like, oh, we're giving Tylenol. It's like, well, it actually works, right? So it's a great medication to give. NSAIDs, usually we're going to avoid in renal failure, not with AKI. They are not. They cause kidney damage more, and you're at risk for kidney damage anyways in the ICU. So usually NSAIDs aren't great unless you're confident that they are on the mend, right? And we have PO opiates we can give. We have PO Percocet and such to get them off the IV fentanyl infusion, and we have what it's called PO sedation. So it's providing sedation, but it's by mouth instead. Instead of the IV infusion, we're doing the PO, and it's a little less dose. It's able to get them titrated off the continuous infusion. So we have clonidine, right? Clonidine was first designed as a anesthetic in the 70s, and then it lowered the blood pressure. It's like, oh, that's cool too. So they started giving it for blood pressure. And usually when they give your first dose of clonidine, they make you give it at night, right? And you can't drive while you're on clonidine for first couple doses because you're going to fall asleep, right? So you might see that patient gets ordered clonidine, they have a 2 o'clock dose, and you give them a report at 7 o'clock. They're not waking up, are they? Right? So it's because you gave that clonidine during the day. And clonidine is literally the same thing as Precedex. It's just PO form. Okay, so it's great in that respect. All right, we have antipsychotics we can give. When we give antipsychotics, we're worried about the QT prolongation. The nice thing is that O for olanzapine has O effect on the QTC, so that's one of our options. If we want to, someone says, can we give antipsychotics, and someone chimes in, but they have their QTCs prolonged, then the next thing is we can try olanzapine because it has 0 effect on the QT. Okay. What else? So other agents, we do have barbiturates and valproate and such, which can help calm someone who's really, really agitated. Like we had a gentleman who had PTSD, and we threw everything at him to get him under control. And then we just need to make them go to sleep, right? Just go to sleep. So melatonin has no side effects besides making you sleepy. So that's absolutely fine to give melatonin to anybody. Right? There's really no contraindication to melatonin. And that's something that once you get them the right sleep-wake cycles, then we can get them on the right path. Okay? So yeah, so Precedex is one of our better medications.
Papá,
Papá,
mamá,
mamá,
aguacate,
aguacate.
parangaricutirimícuaro.
All right. And again, this slide also we're going to touch base on again when we talk about IV titrations. But you do have to be cognizant of the side effects because propofol can lead to, if you keep infusing it over 2 days at high doses, 5 days at high doses, it can start raising triglycerides. So triglycerides can lead to pancreatitis. And you don't want to have someone have pancreatitis and like a pneumonia at the same time. So like heart failure used to be like, people were like, oh no, don't get propofol for heart failure. It's really only this propofol infusion syndrome, which is called PRIS. Here's a propofol leads to what's called propofol-related infusion syndrome, and it's usually with high doses, and that's when you would not get with heart failure. But initially, it's perfectly fine. And then, like opiates, as we know, they cause respiratory depression. And what else do opiates do? Do they make you poop or make you less poop?
Less poop.
Yeah, less poop. They make you constipated, right? And that comes to find out. So you get reported. It's like, when's the last bowel movement? I don't have a record. They've been here, what, 6 days? Well, what's going on? So that's a problem, right? So they need to have a nice quality BM every 2 days. That's our ICU BM protocol, which we'll talk about in GI. So, but opiates for extended period of time, especially if they're like on 4 mics of fentanyl, which is like 400 mics of fentanyl, it's a ridiculous amount. That can lead to severe constipation, ileus, and such. Okay, and fentanyl also causes chest wall rigidity, which is not going to help someone ventilate. All right, what else? We have our Precedex. Usually the only contraindication is like bradycardia, right? That's one of our only things. Benzos, we want to avoid them at all costs. The only time we would give them is maybe someone has hypertriglyceridemia from propofol, right? And they got an AV block and they can't give Precedex. Well, shoot, now I'm tied to a corner. Then you're like, ketamine, right? So ketamine is actually a better medication. And then you're saying, well, we can't give ketamine because they have excessive secretions. It's not a huge contraindication, but someone might be more comfortable with like benzos versus ketamine. And the benzos independently increase delirium, and they also can cause more issues that we don't want to develop, right? But delirium is one of the things that we can try to fix with our early mobility. And how to fix it is not give the benzos in the first place. Because I don't know, you probably overheard, or you guys are coming from the floors, you know, your patient's agitated, +1, +2, +3. What's the first thing they say? Give Ativan, right? So that's the worst thing you do. The only time you should give Ativan is for really 2 reasons in the hospital setting, which are what 2 reasons? Alcohol withdrawal or seizures. They're great for those 2 things. But other than that, there's really no purpose for Ativan. We have other options. We can give Haldol IM. We can give olanzapine IM. We can give other things that can fix the agitation, right? We can move to ICU and start Precedex. So sometimes that happens too. Okay, so Precedex is great because it's non-narcotic, I mean it does not make you sleepy, right? Again, it keeps you nice and awake and calm. Do you want to be awake and calm and on paralytics? No, that's another contraindication for Precedex. It's great, but not for that stuff. All right, so again, the summary is we want to make sure, no sedation is ideal. That's if we can transition from IV to PO, perfect, right? 0 -1 is what we want. We want to do an SAT every shift, get them off sedation, because if you get them, they're on 50 mics of propofol, and you go to 0, and then what happens if they fail that SAT? You have to restart sedation, right? Back at 50? No, at 25. So now it's 25 for the next shift. And then at 8 o'clock, now we go 25 to 0. And they fail, now you're at 12.5, right? So ideally, you're getting off sedation stepwise, right? And then monitor for CAM-ICU, that's delirium, because sedation can cause it, but benzos definitely could cause our delirium, right? Delirium can be caused by benzos independently. Okay, so we're looking at fixing pain, agitation, or delirium. Which one do we fix first? Pain, right? That's our A and our ABCs, right? And what if sedation is not working? So you can get breakthrough pain boluses to give medication for pain control. You can ask for agitation for like PU antipsychotics. So yeah, so you can give these guys to fix it. And benzos, again, they are not the one to give for agitation. And then you can have a second drip for sedation if they're really, really wild. And in that case, we'll talk about this when we talk about IV titrations. When you have 2 drips for the same thing, it's like, well, which one do I go up on, right? Which one do I do? It's like a balancing act, and the Joint Commission doesn't like you balancing. It's like that you're practicing medicine now. So you do need to have a clear guidelines on your drips, which we'll talk about in IV titrations. Right? If you can't oxygenate a patient, then yeah, you're probably going to start another sedative. You might even start a paralytic. And which sedative is not good for paralytics? Yeah, Precedex, right? So you want to make sure your patient's nice and awake and alert. Right? You want to make sure they can do what? It's a RAS of 0 right there. But yeah, that's that's frowned upon. Please don't do that.
Almost like say hi to the camera.
Yeah, so in the Philippines, they make you pay for your care. If you can't pay, then family is the one that's in charge of the ventilator, in charge of the things. Each day they have to fork over $6,000 to $7,000 so they can keep grandma on the ventilator. Philippines is brutal. All right, so delirium. So this is our D in delirium. So our D in the ABCDEF bundle. And delirium is important because it can cause agitation, and agitation can cause more sedation, and more sedation can cause more days on the ventilator, more days in the ICU, more days in the hospital. It's, again, one of our key things we wanted to tease out and fix, right? So pain, agitation, delirium, PAD, these are the guys that we want to fix, right? And yes, he's not a Dracula, he's the Count. So just CAM positive is one way we assess if someone has delirium or not. All right, so we know, again, pain, agitation, delirium, all these things are intertwined, and our goal is to assess if someone has delirium and try to fix it if we can. Right, so how do we know someone has delirium? We have a validated tool that lets us know that they have delirium or they don't, right? And delirium comes from the psychiatric world. So, these guys, they have their DSM criteria, and they want to make sure they meet, item A, B, and C, and then they can say with confidence they have delirium. So basically it means a recent onset of change in LOC. So you have to ask the family, and that's why family is important, is this what they do? Are they usually squirmy at home on their lazy boy? It's like, yeah, they are. They actually squirm all the time, right? They can't sit still. It's like, well, then are they usually able to answer a sentence and tell me if a feather is heavier than an elephant? Yes or no? And they say, oh yeah, it is. Do they usually know what this answer is? They're just like, no, they usually know things. They're actually a engineer down at Lockheed. So, okay. So yeah, that's probably a acute change in level of consciousness, right? And then we look at, memory and thinking changes. Do they have changes in their thought processes? These are definitions of delirium. Okay. It happens about 50 to 80% of ICU patients, and it goes undetected. Actually vented patients, and on ICU patients that are not vented, it's about 50%. So it really goes undetected, and when you don't detect it, they're in the hospital for longer. They're going to get a dose of what? Ativan, and they're going to get more delirium, and they're going to get more, more interventions. They might even get, the consequence of Ativan, which is like respiratory depression, and they might even be intubated. So we want to make sure that we are A, avoiding Ativan, and B, catching it and giving medications to fix it, or non-pharmacological things to fix it, such as family. Family can help reorient, right? We'll reorient too. We'll go in there and tell them where they're at. They're in the ICU, etc. After we quiz them first, say, tell me your name, tell me where you are and such. But we're going to make sure we're reorienting them throughout our shift, right? It's like, who cares? They're in the ICU longer. They made it out, didn't they? Well, then they assessed patients that made it out and said at 6 months, what's their cognition right now, right? So outside of the ICU, after hospital discharge, they have a higher mortality compared to someone who did not get delirium in the ICU. And then they have long-term cognitive impairments, and now they can't understand that a feather is heavier than or lighter than an elephant, right? They don't understand this, right? They get dementia-like symptoms, and this is up to 70% of patients that develop delirium in the ICU, right? Once they're discharged and they follow up 3 months, 6 months in the office, they're like they can't do things. They can't do normal tasks, right, at home, nor can they do it at work. And now they can't work, and now insurance is great in America, right? So now they can't get insurance, and now they have all these problems. There's stress on their caregivers, there's stress on the families, and this is again another spiral that is downward, right? So they're functionally impaired. So that Lockheed engineer can no longer be a Lockheed engineer anymore. Now they don't have a way of income, right? They get 40% of unemployment now. And so it's a whole situation that we have to address and fix in the ICU and assess that it is important that, do they have are they CAM positive or not? Do they have delirium or do they not, right? So the duration of delirium is important, right? So they're delirious just for 1 day, better than if they're delirious for like 3 days or 5 days. Right, you'll have patients coming here and say, oh, just E2H withdrawal. And you realize it's like 7 days later. It's like E2H withdrawal is like 3 days. Why are we worried about this day 7? Okay. And then drug exposure, that's an independent risk factor. So they can have the ventilator, ICU delirium, all the things that independent for the causing delirium, but then you add benzos, it's going to be additive. It's also going to contribute to delirium. The ventilator itself causes delirium. They have sleep disturbances. Sedation will do it. The anxiolytics will do it as well. And agitation and pain. These things are all interrelated. They're all going to contribute to delirium, and delirium contributes to agitation, and agitation leads to pain, and more pain leads to, it's all a downward spiral. And then we introduce any one of these procedures in the periphery here, and that's going to cause even a more exponential increase in the delirium. Okay, so the patient might survive, but what is survival if you can't play your favorite video game, or you can't understand Game of Thrones houses, right? It's like it's not going to be a functional life even. They might be debilitated to the point where they can't balance a checkbook and they're independent even, or no longer independent. Now they have to be in a nursing home, all right? So that's the thing we have to consider when we're looking for a delirium, and that's assessed with CAM-ICU, right? It's done every 12 hours. You don't have to do it every 4 hours. It's every 12 hours, once a shift. You're assessing whether they are delirious or not, right? And you do want to do it after sedation vacation. That's a better determinant if they're delirious or not, because on sedation, obviously you probably can't get a good assessment, right? And that can impair your cognition in of itself, right? So when we routinely monitor and we don't do CAM-ICUs, we miss it about 75% of the time. It's like, because people say, oh, they're just agitated. It's like, well, there's such thing as hypoactive delirium, where they're withdrawn and they don't interact with the environment. Okay, so our goal is to treat the underlying causes. What is something that is causing this? There's something non-pharmacological, like they're not getting any sleep, or they're super dehydrated, or they haven't ate in 7 days. It's like, well, maybe today's the day we put an NG tube and start feeding them. They might feel a little better, right? After that, we can fix the delirium in that state. Okay, so non-pharmacological, we got mobilization, which is our E in early mobility. So that's what we're going to look at that. That's something we can do as ICU nurses and fix their delirium. It's an independent thing that can reduce delirium. Okay. The other things are great, like sleep hygiene is great, right? We can do orientation, keep them oriented. Family can help with that as well. Family can help with sleep too. It's like, you guys got to go home. This patient needs to sleep, right? That can be recommended as well, right? So they're not going to get better if you guys are here all the time. Sometimes they got like potlucks going out in the waiting room. They got a crock pot going, and it's like you got everything going. They got the music playing. You got people sleeping out there because we told them only one person overnight, and you got 4 people out there, and they're changing shifts every 2 to 3 hours. Yeah, that's not the ideal thing. Okay, and then we have pharmacological, right? So antipsychotics can be given, ketamine, and our best friend, dexmedetomidine or Precedex. Okay, so it has a really large impact on patients' survivorship, and also we have more patients that are higher risk, like a dementia patient would be much higher risk than the average person. Okay, so there's a lot of mnemonics to kind of figure out what is causing this, right? So Pinch Me, Think, Smash, Dr. Dre, all these things are telling me that there's one of these things are contributing to delirium, or is it not? Am I thinking of these things? Like Dr. Dre, is there some disease process, right? Is there some kind of drug I removed? Like I took off the fentanyl infusion at 3 mics per kilo per minute, and now they're like withdrawing, right? So maybe that's happening. Or if they withdraw from like steroids, for instance, they're on steroids at home. We took them off when they came in. We didn't realize we had to restart them. That can cause some problems, right? And also the drug addiction can do it too. And come to think of it, steroids also cause independently delirium. So that's something to consider when we have, we're looking at what is causing this, right? And then what else? So the environment can be a situation. So we're thinking of, are they immobilized in bed? They don't know their sleep-wake cycles are off. Right? They don't have their hearing aids, right? They're deaf, and everybody in reports says, oh yeah, they're deaf, they're deaf, they're deaf, they're deaf. But then are we actually getting hearing aids and trying to see if they can have some kind of orientation? So providing glasses, like our friend over there now has glasses, so more power to the person that asked the wife to bring in glasses, right? That gets him more oriented and gets him off the ventilator faster, right? And then just noise reduction. So sometimes we like to tell jokes in the nursing station, and we like to laugh all night long, and we have to make sure we're keeping it relatively quiet for the families. Okay, and don't say the quiet word though. Just like quiet, and then you're going to get code blue next door, right? So yeah, so that's something that we got to think about when we're thinking about the environment as well. And then also they got toxic situations. Their CHF is getting worse. They get more hypoxic because there's something physiologic that's getting wrong. So we take a look at the labs, like, oh, look at that sodium went from 140 to 146. So that could be a reason why they're getting more delirious, right? And then like pinch me is a way to think about. You got pain, the infection's getting worse, especially elderly. They're getting they're not being fed, so that's why we do early tube feeding to get them A, off the ventilator, B, so they don't get delirium, and C, that's calories. You need calories to get better, right? And then hydration, again, we said sodium should be less than 143 ideally. Medications, someone gave benzos, and that's, they just get one exposure to benzos, and they can have an effect from that, about 24 to 48 hours later, where they can start getting more and more delirious. And the environment, we mentioned, different things we can do in the environment to improve their delirium, or things in the environment that are causing their delirium to get worse, like a noisy environment, or lack of hearing aids, or lack of assistive devices, right? And family can help, right? Family can reorient and help as well. Dementia patients have a 6-time higher risk compared to a regular patient of developing delirium, right? Advanced age also puts you at high risk as well. All right, so the CAM-ICU, this is kind of how you do it. We're just going to get exposed to it right now. In our neuro lecture, we'll talk about more CAM-ICU. You'll even role play. You'll assess CAM-ICU on each other. And to do a CAM-ICU, you need to have someone's like, I'm not going to show up that day. All right, so yeah, if you're going to do, you need to have a RAS score to do a CAM-ICU. All right, that's the first step you're actually going to do. That's actually step number one. Number one, RAS score. Are they 0 to -1, -2? -3 is really hard to do all these questions, right, when you are barely waking up to voice, right? So usually as -3 or higher, you can then do a CAM-ICU. So basically you do, feature 3, which is their RAS score, do that first. If that is positive, you're on your way to assess someone's delirium, right? Because to have delirium, you have to have feature 3, 2, and 1. So feature 3 is a RAS score that's not 0. RAS score is -1, you got 1 point. Right? RAS score is +1, you got 1 point. You're on your way to delirium, right? And then the next step you're going to ask is you're going to say, is this a change in their condition, right? Is a change in their mentation, I should say, and their content of thought? Is this different from what they were at baseline at home, right? If it is, then 1 point. We got feature 1 and feature 3. And to have delirium officially, you have to have 1, 2, and 3, right? So we go look to feature 2. And that's where you ask the patient to follow commands. You tell them, squeeze my hand when I say the letter A. And this has been validated. It's 10 letters, and they have to say squeeze on, I think there's like 4 letters. If they get 3 strikes, right, they're out. They failed that one, right? So you say, squeeze my hand on the letter A. You're like, C, A. You pick a word. These are the 3 words that are recommended. You can pick another 10-letter word that has 4 A's in it, but don't be that creative, right? So Casablanca makes the most sense because Save a Heart has 2 A's, you might forget, and A Bad Bad Day has 2 A's in it, which is hard to remember too. So Casablanca makes the most sense, right? So you say squeeze my hand on the letter A. So you don't prompt them. You don't go C, A, S, A, right? You try as neutral as possible, and you have them squeeze. If they squeeze on C, 1 strike. They squeeze on A, perfect, right? They squeeze on the next S, they squeeze on the S, that's a strike. And they don't squeeze on the next A, that's a strike, right? So they have to get 3 strikes. They don't follow commands, right? You're telling them clear commands. Squeeze on letter A, not on the other letters, right? So 3 strikes, and they get that feature positive. And that's how you assess someone's CAM positive, right? For those of you that have been on the floor, those of you guys have been shadowing, hopefully you've been hearing nurses say Casablanca every morning because it should be done Q12 hours. This is how you assess someone that's CAM positive. So we'll get you oriented this and competency on this when we kind of talk about neuro. Okay, so CAM positive patients, how do we, if they are CAM positive, what do we do? So we can stop benzos if they're already getting them. You look at the PRNs and they got 4 benzo Ativan pushes overnight, so let's try something else, right? And then anticholinergics, you just be aware that those do decrease your memory, and especially the elderly can cause confusion, right? And steroids, those independently increase confusion as well. And delirium, sometimes they need it for their lung process or their disease process. But we have to be aware, is like, can we take steroids off today? Usually for all steroid courses, it's 5 days, right? If they're super sick, like ARDS, they might do a whole 21-day course. Right, like what is it? COVID is 7 days of dexamethasone, but most like a COPD patient, 5 days. That's it, right? When they put the order in, it says 30 days, and it'll be there for 30 days. So we want to make sure that we're just doing 5 days or less. We can ask do we still need to continue the steroids, right? And then non-pharmacological things that might be causing them to be delirious. They got alarm fatigue. Right? A nurse is like, no, I want to hear every alarm that goes off in that room, right? So you got to set your alarms appropriately so it's not causing alarm fatigue for yourself, the other nurses, and not letting the patient sleep, right? Like the Alaris pump. Like you have some nurses that will, you know, like if those of you who are in nursing school, they're like, I challenge you to do 3 beeps or less, right? Because you'll have some students or some nurses will, you know, spike the bag, you know, they'll go back and forth. Oh, I got an air bubble, and they'll go back and forth, and it's beeping the whole time. Beep, 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 right? So let's keep beeping, and then the patient starts waking up and starts getting agitated. It's like that's what's going on. That's why, and they're not only they're not going to have confidence in you, but they're going to, and the family's going to be judging you, and the patient's going to get agitated, right, and delirious. Open the shades in the AM, getting your pineal gland happy. Where's your pineal gland at? It's at the top of your brainstem, right? So it's your pineal gland is what is it secretes melatonin naturally, and it does that in response to day-night cycles. So we can just raise the shades up and lower them down at night. That way they get a normal circadian rhythm of some sort. And we can also add melatonin if we need to. Okay, and then removing any kind of paraphernalia. So plastic causes delirium. So take the central line out, take the arterial line out, take the vent off, right? Don't just do it like, oh, that's what Aaron said. No, you guys do the right process, SAT, SPT, and make every effort to get it out, right? Say, hey, do they need this Foley catheter? They're an end-stage renal disease patient. No, we don't. Take it out, right? Do they need this arterial line? They're off pressors. Let's take it out, right? So that's the idea behind taking tubes and lines out, taking restraints off, trialing it, right? You gotta look at this family. It's like, you're gonna watch, right? So you can have the family there. They can watch and make sure, and like they're gonna ring the call bell. You're going, what happened? Oh, he's pulled his tube out. So, why didn't you stop him? All right. So yeah, but sometimes you do have families you can trust, and they will, they'll be right there. They'll go into your other patient's room and say, hey, they're touching their tube right now, right? So that's the idea behind using families as well to help get them off restraints, because that can make them more agitated than not. Okay, pain control, as you mentioned, pain causes delirium, so might as well assess it and treat it. And the fixes, right? So we have antipsychotics, there's our friend Dex, and propofol can help, and not benzos. If we have a choice between a Versed drip or a propofol drip, we should be erring on propofol. Okay, and of course, extubating, taking the tube out, that's going to help fix delirium, right? So we have a patient that's too deeply sedated. That can cause delirium in of itself. We should not have -4, -5. We need to take off the sedation. Someone is super positive. Do they have pain? All right, let's fix the pain. Do they have, give the analgesic? If that's not working, we could consider other drugs to fix their delirium. All right, so an example of some of our drugs, and again, we'll talk about these more with IV titrations, but we talked about antipsychotics being our PO sedation. We got Precedex, their go-to. Again, we got clonidine, it's just our PO form of that. So we can start them on those. As long as their blood pressure is good, you can start PO clonidine, right? So these are things we can give. Remember, Precedex is the cat's meow. That's our go-to drug. And propofol versus an alternative, such as midazolam or Versed, right? The idea is just not to give benzos. Don't give lorazepam. Chlordiazepoxide is a benzo in disguise that we give for E2H withdrawal, Delirium, right? So that is, it sort of works for E2H, but it was sold by pharmaceutical companies in the 70s to people to use benzos for alcohol withdrawal, and it actually doesn't work. So it's better to use something else. So they filtered out the phenobarb market. So phenobarb works great for alcohol. So it's actually a better drug for fixing alcohol withdrawal. And then Versed and lorazepam drip. Sometimes you need it. If they have like active seizures, you do need it, right? What else? So these drugs, yes, haloperidol and quetiapine or Seroquel, so QT, they prolong the QT. So you should know how to measure QTCs already. And when your QTC is getting longer and longer and longer, then we should assess, is there some reason for this, right? It's like, well, but they need the Haldol. Well, we have something that has no effect, right? No effect on it is olanzapine. Olanzapine is great for someone who has a prolonged QTC. Okay, so D is detrimental for the ABCDEF. It's not going to get someone out of the ICU when you have delirium, right? So they will require more sedation, and that will cause more delirium. That will increase their vent days, which will also increase their ICU days. And each one of those things increases your mortality in the hospital setting, right? And we have the other drugs on the previous page, which can help abate the delirium. And also taking the ventilator off will help as well, right? Decreasing mobility, that will also cause delirium. So we want to improve mobility, right? So D is part of our ABCDEF bundle. And we had C that we talked about our choice of sedation, right? So the choice of sedation is to use, when you're like bringing a boyfriend to Thanksgiving dinner, you don't want to be bringing Versed and fentanyl, right? Those are not your go-to ones. Those are going to start causing some problems, right? The guy you want to bring is who? Precedex. All right, so E for L mobility, or early mobility, right? So this is where we can fix delirium, right? And it can have a lot of positive outcomes.